is Dr. Betsy Grunch. Dr. Grunch is a neurosurgeon at the Longstreet Clinic in Gainesville and completed her residency at Duke University. She has a special focus on deformity surgery, motion preservation, as well as minimally invasive surgery. And she's going to speak to us today about a single-site experience with a bone-anchored annular closure device, preventing reherniation and reoperation after lumbar discectomy.
Everybody's in the back. So, is there like a laser? No? Okay, that's fine.
You won't have that one.
Sure. Great. So I'm Dr. Betsy Grunch. I am in Gainesville, up at Northeast Georgia Medical Center. I've been in practice for 10 years now. Thanks, Jay. I do mostly spine. And I think everybody that does a lot of spine surgery knows that the most common problem that we treat is lumbar disc herniations. And I would argue it's probably one of the most important things that we treat. I think as a neurosurgeon, motion preservation is so important for long-term spine health. And as someone myself that's experienced a lumbar disc herniation, it can be quite a life-changing experience for the patient. And so, how we treat these can really affect their lifelong spine health, and I think that's so important to understand, because if you have someone that has a disc herniation that goes on to discectomy and reherniation and then subsequently ends up with a fusion, which half of them do, that can affect them lifelong for development of additional spine problems. And we've all seen patients like that had a disc herniation in their 30s, go on to reherniate, need a fusion, and then every 5 to 10 years end up having more spine surgery, and then they end up with us at 65 and they've had 8 surgeries, and they're just in chronic pain, and it's a real problem. And the biggest thing is we don't really have a good solution to preventing reherniation. So these are my disclosures. So the history of discectomy, first one was done in 1908 in Berlin, and really the first proceduralized discectomy was done in the 30s. And then these are the developments of how we learned how to treat disc herniation with a microscope in 76, the MRI in 77. And then I was a little surprised in 93 for the endoscopic discectomy, because I thought that was newer, but endoscopic surgery started in the early 90s. And really 97 with the development of tubular retraction has been the last innovation in lumbar discectomy, so in 25 years almost. And so, there's been many suture-based. If any of you have had experience with X-close, which I have, and some other devices that don't really work that well. So that's what I'm really excited to talk about, because I think, I hope I'll change your opinion on discectomy and motion preservation, because it really has impacted my practice quite a bit. So, we have these patients, you get in there and you do the discectomy, and you have patients that have really small annular defect, tiny, and by small I mean under 6 millimeters. And then you have these patients with big gaping holes, 38%. And you've seen these MRIs, these patients that come in with this massive, tall disc and this huge herniation, and you're just, that's what scares me the most, because I'm like, that patient is at such a high risk of reherniation. And those are the ones that I don't like to see. The collapsed bone-on-bone and disc herniation, those are the ones that I love. But so it's these ones. This is a big problem. 1 in 4 of them will reherniate, and reoperation for a lumbar disc herniation is the #1 predictor of disability. So 73% of reoperations are from these patients with large annular tears or defects. And so, anytime we do a discectomy, we all have kind of the ways we do discectomy. You have 2 options really, and neither option is great, but you can do a really aggressive discectomy and leave less disc to reherniate, but then those patients have increased risk of back pain long-term, discogenic back pain, go on to progress with their degenerative disc disease, and then represent to us later for chronic back pain, or just live with it. Or you remove less disc, just remove the fragments, and their disc health is good, but they're at a bigger risk of reherniation. And so I think that's what I kind of go back and forth on anytime I was doing discectomy prior to this device is, which avenue do you take? And I would argue that I try to do a more conservative discectomy, but my rate of reherniation was higher. And so anyway, so this is kind of the foundational study by Carnegie, and this was done in 2003. But what he did was took 187 patients and measured the rate of recurrence based on the size of the annular defect. So if they have a small annular defect, the rate of reherniation was 1%, rate of reoperation 1%. But those ones with the annular defects that were larger than 6 millimeters, 27%, that's 1 in 4, and almost all of them went on to needing a reoperation. And this is, this is not a good solution. So this is the, just to kind of talk about reoperations and how it kind of can affect people. I mean, they have a 3 times higher disability and pain score. 44% of them are not satisfied with their outcome after revision microdiscectomy, and 88% use narcotics. And this is just the ODI, VAS, and VAS back score on those that are reoperated or not reoperated on. And yeah, 56% of those reoperations are fusions. And I don't know, I mean, we all kind of have our kind of go-to. I was initially earlier in practice doing the 3 strikes you're out technique. I'll do a reoperation for a reherniation, but the 3rd time they're definitely getting a fusion or something else. And then kind of as I've adapted my practice, the 2nd time around, if they have preserved facets, I'll talk to them about disc replacement if that's something that their carrier talks about, just to try to do my best to preserve their motion, because I know that'll be best for them long term, assuming that they're a candidate for that. But it's just the challenge that we deal with in conversations you have to have with these patients. And sometimes these patients, I mean, this is a really traumatic mental thing for them, especially if they reherniate early. They've taken off of work, they've changed their life, and then they immediately reherniate. They're like, look, I don't want to do this again. Just fuse me, whatever you have to do. I just want to move on with my life, and that can also affect their job and their life altogether. So this is a device I want to talk about. It's the Barricaid, and it's designed to close that hole. And I found out about it actually in COVID. I was just looking through a white journal, and I saw like a little, I used the X-close, or attempted to when possible. I was just flipping through the journal, and I saw this device, and I was like, oh, this looks kind of intriguing. So I did a Zoom meeting and kind of learned about it, and I adapted it to my practice in 2020. But essentially what it is a bone anchor device with a little occlusive component that's made of mesh, and it's a single disposable implant, super easy to use. So that's what we're really talking about today. This is how you measure the size of the defect. You can use a pin filter, there's a measuring tool. You trowel and place the implant. Here's kind of a video. So after you do discectomy, you'll just measure the size of your defect to determine whether or not it's appropriate for the implant. You do the trowel, and again, the facets are preserved. You're not really doing anything to destroy the natural anatomy. Place the implant in, and when you do that, that mesh protective barrier, or the Barricaid, goes into place. This is on the fluoro, and that's after implantation. So just, you have that part that goes into the bone, and then the other part that goes into the annulus. And then another concern is, what does it look like on re-imaging? If we get another MRI, is there a lot of artifact? Can you see if they've reherniated? That's what it looks like on X-ray, and this is what it looks like on MRI. Very easy to visualize around the implant. There's not a lot of metal in there to give any artifact other than right in that implant that you implanted, and on CT it's pretty easy to identify as well. So this is the level 1 randomized control trial, superiority trial that was done in Europe. This is the 5-year data that they have that was published in JAMA 2021. And those 21 sites in Europe, they had 550 patients enrolled, and the follow-up was through 5 years. They did annual X-ray, MRI, CT, and then here are the results. So this is the comparing it to the Cherokee study that I went through earlier, and their rates of reherniations, 27% in the large annular defect, and this study basically mimicked that, 25%, and then this is a reoperation, 21% to 16%. So very similar results to that initial foundational study on the rate of reherniation in those patients with large annular tears. So this is with the Barricaid. So Barricaid reduced reoperations by 50%. Here you can see that with the patients that received the Barricaid, the rate of reoperation was 12%, or excuse me, the rate of reherniation was 12% and reoperation was 8%. So this was proven to be superior over microdiscectomy alone. And this is just the data on a bar graph of reherniation, symptomatic reherniation. Of course, that would qualify as patients who were actually having symptoms and not that just had reherniation as defined on imaging, reoperations, and hospital readmissions. And then this is with the Barricaid, and what you really can kind of see on this graph is how you maintain that over time. So initially, you know, the biggest risk of reherniation is in year one, but patients can continue to reherniate as time goes on. And, you know, they're not out of the woods in the first 12 months or so, but what this shows is, you know, with the Barricaid implant, that rate of reherniation is persistent over time, which I think is really, really important to kind of keep in mind. This is the post-market US study to confirm those European results. This is currently in progress. This is just a methodology. I think they're 3 months into this data. And these are just disherniations 45051. That's the FDA approval for this implant. And so far, it's confirmed that real-world, the randomized control trial results with 1.8% versus 1.9%. And then this is the study that I'm currently working on. It's a real-world study, all comers. And the purpose is really to just kind of use real-world setting for all comers, all patients, and do a retrospective chart review of patients that only had Barricaid to see what their outcomes are and what the reimbursement data is, which I think is really the biggest concern with this implant. And then the endpoint is at 3 months. So this is my data. I've enrolled 18 patients, treated 19 levels. One patient had this herniation, another level, avid CrossFitter, we all see those. And 56% male, average age 54, BMI 27. We do live in Georgia, so. The 3-month data that I had one patient that reherniated and needed a reoperation. Of course, he was a surgeon, unfortunately. But no device-related complications. So this isn't, I don't think this is really gives us justice just because my numbers are low, but that one patient did make the rates go up, but essentially, you know, all this is pretty similar across the board. Oh, this is the old slide, shoot. Oh, there we go, okay. So, so basically, you know, we're using this post-market real-world study to treat patients with Barricaid to get the rates of symptomatic reherniation, reoperation, and the adverse events are all very low. So this is my experience to date. I started implanting the device in 2020, and I've identified 120 patients preoperatively to get prior authorization for Barricaid. Unfortunately, one of the realistic problems with this is prior authorization through most commercial carriers. It's an experimental device. So I've only been able to have 54 patients going into surgery that I could use the Barricaid, and some of those patients were actually patients that would pay out of pocket for the device as well. So that's not necessarily the patients that were actually prior authorized with their insurance. And 33% of those went on to implantation, which basically means, you know, 21 people in the OR, when I identified their annular tear, it was too small for the Barricaid, so they did not get it. Here's just some examples. I mean, this is pretty straightforward, but, you know, we have a patient with a old lady with a pretty tall disc and a herniation that was symptomatic. So her intraoperative annular tear was 4 by 6 millimeters. The minimum size is 6 millimeters wide because the implants are 8 and 10 millimeters. And this is how you would measure it in the OR. I do all my cases, almost all of my cases, tubular. And it's really easy to visualize around the tube as well. So the biggest thing is you just have to confirm that you get a full thickness tear. So if it doesn't actually go through the annulus and into the nucleus, then obviously you don't put in the implant, but if a full thickness tear of that size, then you would get it. And you really, the biggest thing is with even open surgery is you have to have a parallel access to the disc, because the implant needs to go exactly parallel with the implate. So you have to wind your retractor or change your access there to make sure that you get a good visualization on x-ray as well to get that implant deployed correctly. So this is just the trial. You want to verify that the anchor is going to go into the implate, retract the nerves, make sure everything looks good from a visualization standpoint. It's on the vertebral body before you put in your implant. And then you can put in the anchor superiorly or inferiorly. I use whatever I have good access to do. Or if the tear is up against one of the implates, you want to go to where the tear is to make sure that you get good coverage. So it does slightly recess within, so you want to get a few millimeters into the vertebral body, and then this is just the tantalum marker to identify that your mesh is going upwards to provide that barrier. And it's, yeah, slightly countersunk as I said. So how do we know if a patient is a candidate for the Barricaid? Their disc height has to be, and the posterior disc height needs to be 4 millimeters. That being said, some of them will have these little osteophytes and stuff. You can get a kerrison in there and remove it if you need to make that access window 4 millimeters. But if you've got somebody preoperatively that's bone on bone, they're not going to be a candidate. You're not going to be able to fit the implant in. So I don't even worry about prior authorization on those patients. That's really the only thing. It needs to be 4.5 or 5.1. You can do it off-label higher up. It's also a little difficult to access the higher you go up because you do need to have that canal diameter to get the implant in. So you can, this allows you to do a disc-preserving discectomy. So in my practice, what I do is if the annulus is already torn, I go through that. I try to identify the weakest spot of the annulus or the tear because, you know, sometimes the tear can be kind of medial and you don't want to like kind of cut a second tear laterally. You really want to go through the original injury, do your discectomy, whatever's herniated, I'll irrigate the disc space out, then trowel and go. And this process takes less than 5 minutes, so it's pretty quick. So you want to identify the size of the tear. And then of course you'll have little women, a very narrow canal. I'll put the trowel in, I'm like, you know what, this is going to be too much retraction on the nerves. I would need to take more facet down, maybe this isn't a good candidate, etc. Someone with a repeat discectomy, there's gonna be a lot of scar tissue, hard to mobilize the nerve root, you know, probably not a good candidate. And that one reherniation in my practice that I did have was a revision. It was a hard case, so probably not fair to include it. And then S1, so it sometimes can be hard to put the implant into S1 because that bone is dense. And that anchor, there's a lot of malleting. And it can be a little challenging. So if I am at 5.1, I'll try to go L5 unless they're a little older, their S1 may be softer, but in these 40-something-year-old guys, it can be sometimes a little challenging to get the anchor started. So this is an example of one that's probably not 4 millimeters, something that, is this disc really worth salvaging? Probably not. There's a lot of motive changes already, so you know, by preserving with the Barricaid, I'm not sure you might gain a whole lot. This is someone with a really narrow canal. I think this diameter I measured to be like 12 millimeters or something. So if you're going in here with a tube, this is not going to have to take down a lot of facet accesses, so probably not the best case. And of course, something like Betsy would absolutely not want to do this with the Barricaid. That looks scary. So reimbursement, that's really the biggest thing that I think is the rate limiting step with adaptation of this into practice. There is a C code, it's the C9757 facility code, and for us, there is of course the 63030 discectomy code, and then this is the ever hated unlisted code, the 22899. And I'll show you the reimbursement on this, but this currently, there is no CPT code for the bone anchor device. This is the ICD-10 code that you'll have to use to, in your operative notes and in your diagnosis to get the prior authorization. This is something that probably none of us have ever used because I just figured out that they have this code, but it's M51.82, identifies large annular tear. Or this one, it was at L5S1. So this is the reimbursement data, so this is actually really impressive. This is hospital and ASC. So reimbursement for discectomy plus Barricaid, and then at ASC the same. Now, again, don't want to deceive anybody, this would also include the cost of the implant as well. So the implant still, minus the cost difference, you're still making money. These are the national averages, hospital discectomy or the ASC. So you can see that it kind of spans across the board over the years. It hasn't reduced at all. So this is our summary report for claims reviews, over 300 claims. And again, that just mimics the same. You get 14 at the hospital, 9,800 at the surgery center. And then this is all comers with that unlisted discectomy code. You know, it's an average repayment to the surgeon by $500. And of course, that's on average. Some payers may get more, some payers may get less, but that's an average. And that's excluding Medicare and workers' comp, I want to point that out. So yeah, so thanks for having me. Love having my family here every year, except for 2020. 2008 was a bad year. We didn't take any family pictures. My daughter was 10 days old. So yeah, sorry about that. But anyway, thanks. Any questions?
What size tube do you use?
I use 18, and if I know L5S1 is pretty big and I'm using the Barricaid, sometimes I'll do 20 just to help a little bit with visualization. 16's a little bit of a challenge trying to visualize. I will use 16s, but not for the Barricaid. Yep.
Betsy, great talk. It's always an interesting device that we look at. I mean, two questions. One, it adds significantly to the cost for a very low cost procedure, you know, high volume, low cost procedure, and that's always been a big barrier for us to prevent reherniation in that subpopulation that's going to have it. The second question is really related to the only issue with these patients isn't just reherniation, right? Some of these patients go on to have progressive degeneration of the disc and develop instability and those types of things. How do you deal with patients that then become unstable at a level where they had prior discectomy and you have a Barricaid device in there that now go on to need a TLIF or a lateral fusion or something else?
Great question, yeah. So, so the first thing I would argue that I think with a disc-preserving discectomy, your rate of advanced progression of degenerative disc disease is less. I think that with an aggressive discectomy, you're gonna have these patients that go on to develop severe progressive degenerative disc disease. So I think salvaging that nucleus is really important. Now, I have done, since I've been doing this for 3 years, so I have reoperated on several patients with axial back pain. Maybe the discectomy wasn't there, or the disc herniation really wasn't their symptomatic issue, but I've done both anterior and T-lifts with patients with the Barricaid. It's very easy. I mean, the little wing, there's a bone anchor and then there's a little wing. You can get a pituitary and literally just rock it back and forth and break it off. I've left it in place on ALIF. I don't even bother with trying to get the anchor out. I just leave it in there and pull the mesh out. It's super easy. I've done that probably a handful of times. And then through a TLIF, when I did have a patient that needed a TLIF, I just came out on the opposite side because that facet was preserved. I just didn't want to really mess around too much with it. But yeah, so hope that answers your question. Yes, sir.
How much time does this add to your discectomy?
So initially, when I first started doing it, I would say it added about 20 minutes, which is a little frustrating. It's already a quick procedure. It's kind of annoying to have to do that, especially if you're trying to, you know, be efficient. But now that I've become pretty proficient at it, know like how much bone I need to remove, etc., it adds literally maybe 4 to 5 minutes. And you know, I always think of myself, if it was me on the table undergoing the procedure, what would I want for myself long term? So I try to put myself into that position for every patient and take the extra time to do what's right. So, but yeah. Thank you.